make it bang on 12 noon. So welcome everybody to the Extraordinary Trust Board meeting. We have a very specific 3 agenda item agenda, and we have lots of apologies. So Sharon, could you just read out the apologies that we've had, please?
Yes, of course, Tessa. We have apologies from Jill Harrod, Sarah Dugan, Mark Yates, Steve Peake, Jamie Morris, Matthew Hall and Janet Clark.
Thank you very much. That's great. So we haven't got any minutes or anything to approve today. So I'm going to take us straight to the first of the papers, which is over to you, Sue, for the Athlone closure and hospital at home paper. Obviously, you can take it that we've all read them, but just highlight any key issues that we need to be aware of and the decision that the board are making today, please, Sue.
Yeah, no problem. Thank you very much, Tessa. I think it's worth reflecting there's quite a lot of paperwork in the appendices, so you have a lot of detail which felt really important to put into one composite conversation we're having at board today, because obviously we are making a recommendation to approve the closure of Athlone Ward. Just a little bit of background. I've taken a number of updates around the hospital at home service through Trust Board since the service came on board, which was around June 2020. So to recall that this was a response to the COVID pandemic to effectively reduce down the footfall of older adults into our inpatient environments, and also to free up potential capacity for any acute surge. So the hospital at home service came in that June 2020, and we then formally moved it into the older adult mental health service in the October of 2020. There have been a number of evaluations that have taken place. Headlines are in the business case, which is part of the pack and the appendices. Just to state that we've done a regular engagement and 2 formal consultations around this. The feedback has been consistently positive, and most patients and carers really welcoming having an alternative to admissions. It's worth noting as well, this doesn't mean we don't have beds for older adult mental health. We still do on the Bromsgrove site. So it's important to note the process that we've gone through. So the service change process, which is an NHS England process, has now been concluded. There are 5 NHSE tests. You'll see that in the covering paper, and we have complied with all of those. We've also taken the service model through to the West Midlands Clinical Senate. Again, it was positively reviewed by Senate. Some very specific recommendations, which I've outlined in the paper, and all of these have been actioned. So what we have in front of us then is the full business case and the Clinical Senate review, and the board is therefore asked to approve the permanent closure of Athlone Ward. It's an older adult mental health inpatient unit, and then to permanently establish the hospital at home service. Finally, to note that the Integrated Care Board looked at the same paperwork on the 15th of March, and their recommendations were approved. So they have also approved the permanent closure and the permanent commissioning of the older adult mental health hospital at home service. So without going into too much of the detail, as I say, I think this has gone through to board over the last 3 years, really, since the service first started in the pandemic. But this is formally bringing this process to a conclusion today.
Thank you, Sue. I'm going to take Chair's prerogative and just get one point for clarification before I see if anyone else has got any questions. I know we've done an awful lot of work, but we've talked about the patient and carer engagement piece, but can you just confirm that all of the workforce staffing side of things has gone through appropriate change management consultation and that staff are happy with the changes that have gone forward?
Yes, Tessa, that's an important point. Yes, the processes around change management have been concluded. The majority of people in the hospital at home service have actually been recruited into that service over the 3-year cycle. Some of the team did want to remain in inpatient areas, so they were redeployed into Newhaven, and that was a choice. There were some individuals that related to cleaning and to physio, and again those have moved over to Newhaven, so there are no stranded workforce costs. The processes we'd need to have been complied with and completed, and the staff are really welcoming the permanent establishment of the new service.
Thank you very much. Natalie, I can see you've got your hand up.
Thanks. Not so much a question really as a comment. Thank you, Sue. Incredibly comprehensive paper, and it was really helpful to see all of the detail. And from a professional and clinical perspective, it just embraces, doesn't it, so many of the philosophies of home first, the principles of least restrictive practice, enabling people where we know that they maintain their best level of conditioning to be at home with care that keeps them there. So I think it's a great ethos, it's a great model of care, and I'm happy to support. Just wanted to make those points.
Thank you very much, Natalie. I can't see any other hands up, so can I just ask then for the board to approve the permanent closure of Athlone Ward and the permanent establishment of the Hospital at Home service? Everyone happy? Everyone's thumbs up or nodding, so that's good. So that's brilliant. Thank you. First action completed. That takes us on to you again, Sue. The Mental Health Collaborative changes to approve the process to become a joint committee from the beginning of April.
Thank you. And again, quite self-explanatory. We did talk about the Mental Health Collaborative arrangements at our 8th of March public meeting, and we approved in principle then the transition to a joint committee between the Trust and the ICB from, well, this next month, so April, with this full delegation still scheduled for the 1st of October 2023. We recognised at the board level that there were a number of high-level actions that needed to be completed, and so I pulled those into an action plan, which is an appendix to the paper. That includes the work that we need to conclude around the trajectories for Section 117 and the financial management of those, the quality assurance framework, and any transfer of resources for the Mental Health Collaborative to function effectively. They're scheduled now over the next 2 months and will be overseen by the Joint Committee. So it enables us to have a really clean line of sight to ensure that those actions are completed to move through to the full delegation in October. There is also a September board where we will take that final decision to proceed. So today is not a commitment to the broader piece in terms of onward approval. This is very specifically the approval to move to the joint committee between ourselves and the ICB from April, noting the work that is outstanding, the timeframes for completion, and then the final decision that will be made in the September when all of that is, all of those actions have been completed, and we'll have the detail to consider over the summer.
Thank you, Sue. Anyone got any questions on this paper? I think it's just worth saying it had a really good discussion at the last Mental Health Collab committee. Jamie, as the chair of the committee, was happy with the proposed changes, the new terms of reference and so on. Sue?
I've just realised one point that we really need to bring through is that the Integrated Care Board also considered this on the 15th of March, and they have supported and therefore approved the move to the Joint Committee from April.
Brilliant. So it sounds like everybody is happy. So can we as a board approve this move from the beginning of April? Yeah, everyone's okay with that. Brilliant. Thank you very much. And that takes us on to our third paper, which may need a little bit more debate and discussion because it's been a moving target over the last few weeks, although we had a very good briefing at our previous meeting. So Rob, over to you for the revenue and capital. And just to be clear as to what we're approving, if you could, as you sum up at the end, please.
Yep, thanks, Tessa. And yes, as you said, I brought a paper to the March Public Board, which this very much builds on. And picks up the agreed actions at that point. I'll just cover off a little bit of the broader context, if I may, in terms of the system and where we are, before I get to the specifics about the report here, and then I'll draw out specifically the revenue and capital part, Tessa. So just in terms of where we are, I think all board members will be aware that we're about to enter a particularly financially difficult year ahead. We are seeking to set a system financial plan that meets the national requirements of being one that is financially break even. And at the moment we are not there. There have been several briefings and meetings with both regional and national colleagues during the past 3 weeks around that. And the actual point for submission of the system and our own individual plan is today. So we are at the point where the plan goes in. I should say it is highly likely that only a minority, a substantial minority, but a minority of the nationally submitted system plans are accepted at this point, and we are expecting that there will be a further process through April for the majority of systems to further refine their plan. Clearly that's not where anyone wanted to be at the start of the year, but just is a reflection of how difficult the circumstances are in terms of balancing the finances, the recovery and the quality requirements. So that is work in progress, as I say. On the plus side, we have seen both within our trust and within the system significant improvement in terms of the plans and the overall plan. So we are moving in the right direction, if I can put it that way, but we are not there yet. In terms of where the system position will be for today, we are currently submitting at a deficit of approximately 55 million, which, as I say, is not where we need to be, but is where we have got to. Clearly, that's an aggregate of the 4 statutory organisations within the system, so three trusts and the ICB, and we're anticipating that there'll be further work up over the next 2 or 3 weeks to seek to improve that and meet the national planning requirement. If I could just turn to our plan, therefore, and what we have, and this will build on what I talked about in early March. We've got 2 elements to the revenue plan that I want to draw out, really. We have the underlying £7.4 million pound gap that we were aiming to bridge as of March, which is the gap between the income and the expenditure. There were at March a few items of income that we needed to completely clarify with system partners. That has been completed, and there were some elements of the expenditure that we needed to just confirm internally, which again we've completed that. Neither of those have actually changed the overall gap that we're seeking to bridge. And you'll recall that as of March we had identified around about 5.2 million of that gap. We felt there was a plan and a route through to get to the remaining 2.2, and I'm pleased to confirm that what's set out in this report to Trust Board and the budget is that we have managed to close that remaining 2.2 million gap. That plan is not without risk. You'll have recall I mentioned that. However, it is credible in terms of what we have, and fundamentally there's 3 strands of efficiency that sit behind that. We have some elements of more traditional cost out savings, which cover both corporate and support services and some of our frontline services. We have elements of productivity gain, where we're either receiving additional income to reflect the fact that teams are delivering more than was set out with their funding, and therefore we're able to leave the productivity gain in and go further, and that's been cash backed. We've got some areas where we're taking some cost out against productivity gains. And then we have a very large area which is around reducing agency costs, and that will be the predominant focus of the plan for most service areas, particularly our wards and our supporting medical staff around those areas. So those are the key elements. On top of that, we have another work strand which is around some of the technical financial opportunities and actually the level of risk reserve we're carrying as well. So that all comes together with a plan for 7.4 million. We have considerable work underway internally to ensure that we have a sound plan to deliver that. And in terms of agency, I would just draw out that Matthew Hall, our Chief Operating Officer, is going to be the senior responsible officer for that programme. However, we have around about 5 work streams within that are being led by executive members of the board to kind of really focus on delivery, and they cover all the things that you'd expect to see across both the demand side and the supply side of that. We will take all of that detail through internal committees and Finance Performance Committee in particular, and we have a Programme Management Board that is overseeing that. The other part I need to draw out then that is new, although I did allude to it in March, is that we were likely to be asked to go further by the system to support the system position. You'll note that we've got a 2.7 million surplus, and the 2.7 million is actually all accruing from windfall gains that are additional income or elements of natural slippage that will be there within our plan that have been confirmed since the March point. So there's 2 elements of additional income we're receiving, which were released nationally. One was a clarification around the Elective Recovery Fund, for which there's an element that comes to our trust, and one was around some additional funding from the national team around increased capital charges. We already had those in our plan, so those represent something we can take to the bottom line. We've also confirmed the amount of funding that's coming through on some service developments, and just due to the timing of confirmation of funding and when they start, there is an element of slippage on those when we'll actually have staff in post, and that again has been offered up. So that's the 2.7 million element. I'll turn to what I need the board to do with that in a moment. Tessa, if I just touch on the capital. The other element of the capital of the budgets is the capital. And again, this is a little bit more straightforward. You recall in March, I presented a capital programme which was in line with national planning guidance, overcommitted by 5%, really to provide assurance to the national team that we had plans in place to fully utilise the capital, and should there be slippage in other areas, we'd be able to accommodate that within our schemes. For the final submission, we've been asked to remove that overcommitment, which is what we've done. It doesn't materially change any of the schemes that we had or take out priority schemes. It just affects how we've prioritised some of the other elements we would have. So really the capital programme is as presented in March with the overcommitment element taken out, and we are in a position to move forward with that. Most of the capital expenditure in the plan is actually large schemes that are rolling over from the 22-23 year, so we're not in the position of significant risk of startup and roll forward, so that's good. I'll take questions in just a moment. Before they do that, just to be clear what I'm looking for, I'm seeking approval from the board of both of those plans, the revenue and the capital programme. I would caveat the revenue programme in that that may change in April, subject to the further discussions that we have as a system. But essentially the underlying 7.4 million element is the key part in terms of this trust being able to set a balanced budget. we would deal with the other items as and when they come through on a similar basis to how we've dealt with the 2.7 million. So it would be that bit that it would vary in my mind if we do change going forward. I can see Martin's got a question, and there may well be others. So I'll pause there, Tessa, if that's okay.
Thank you, Rob. Yeah, that's lovely. Thank you. Martin, would you like to come in and ask your question?
Yeah, thanks, Robert, and a very clear paper that builds on where we were in the middle of March. I just wondered, can you outline, if any, what risk there is to our revenue streams if the system doesn't agree the balances associated, get an approved budget going forward, and what might be withheld and what risk that presents to our numbers?
Yeah, I don't think, well, to be clear, I don't think there's a risk in terms of leaving us an income shortfall. I think any changes that would be made to the income would have a corresponding reduction to expenditure. That's not to say quite clearly that we may not get into a situation of having to make hard choices about services or things that we're delivering that we can't, but the way the system is working together, it would not be a arbitrary reduction in income with us then having to plug that gap as an additional efficiency effectively. We would have a plan that talks about a difficult choice potentially, which results in some sort of reduction, but there's an offsetting reduction in expenditure. The other side of it could clearly be, Martin, there's something else in terms of the same sort of thing as the 2.7 windfall gain that we've had, and it could play through as a more of a non-recurrent benefit in that way. Again, I don't think there's easy things there. They would potentially have to be, more difficult, but it is possible that there's something in that sphere. So hopefully that provides the assurance you need.
Yeah, thank you.
Thank you, Rob. Any other questions? I can't see anybody else's hands up, so thank you. I agree with Martin, Rob. It was a very clear paper enabling us to see what the changes and shifts were and what the underlying position was. So we're being asked to approve both the plans with the caveat that on the revenue one there may be further changes due to system shifting, which has to be done through national conversations. So is everybody happy to approve both aspects of the plan? Yeah, looks like everyone's giving that a thumbs up, so thank you very much, Rob. And I think, unless I'm mistaken, that takes us to, well, I've locked myself out of diligence, I can't even see the agenda. Any other business? Nobody's notified me of any other business, and I'm assuming that we'd agreed three items, there is none. So I would thank you all for your availability and attendance at this extraordinary meeting. Martin, thank you for dialing in from France. I don't know whether it's any sunnier or warmer than Worcestershire, but it's not great here at the moment. And thank you all very much for your time today. And I will say goodbye to everyone. And Laura and Adele, we can stop the live streaming. Thank you.
Thanks all. Bye.
Thank you all.
Bye.
Bye. Bye.